Imagine this. One day, your child starts hearing voices that aren't there. She screams, runs away, and becomes convinced that someone is trying to hurt her, that someone is poisoning her. Then she points at you and says, "You're not my parents. You're imposters." And she insists, "This isn't my home. My real home has been copied." What would you think? Schizophrenia or a sudden psychotic episode? In the hospital, though, doctors may first worry about something even more serious. Conditions like encephalitis or autoimmune encephalopathy. Here's the case. A 17-year-old girl got what seemed like an Abichni cold. Soon after, she developed auditory hallucinations, intense paranoia, and delusions where she misidentified people and even places. In the end, it wasn't that her mental health suddenly fell apart. Her brain had been missing a critical form of energy support for a long time, and the infection pushed that fragile system completely out of balance. She was diagnosed with a rare, but treatable, inherited metabolic disorder, IEM, a type of creatine deficiency syndromes, CDS, known as GAMT deficiency. It can show up as autism-like traits, hyperactivity, and seizures, and in some cases even hallucinations and delusions, so it can look exactly like a primary psychiatric disorder. But when you find the real cause, there may be a path forward. So in this video, we'll break down why GAMT deficiency can mimic psychiatric illness and what clues can help us catch it before we miss a treatable opportunity. Today, I want to talk about an inherited metabolic disorder, an IEM, that's often mistaken for autism, ADHD, epilepsy, or even a primary psychiatric condition, Creatine Deficiency Syndromes, or CDS. And first, don't think of creatine as just a gym supplement. Inside the body, it acts more like a rapid energy buffer for the brain and muscles. When the brain or muscles suddenly need a surge of energy, creatine helps meet that demand quickly, so things don't crash. If someone is born unable to make creatine, or they can make it but can't deliver it into the brain and muscles, that's when CDS can happen. CDS is usually grouped into three main types. 1. AGAT deficiency, also referred to as GATM deficiency. The first step of creatine synthesis is impaired. 2. GAMT deficiency. The second step of creatine synthesis is impaired. 3. SLC6A8 transporter deficiency, also called CTD or CRTR. Creatine is produced, but the transporter doesn't work, so creatine can't get into cells. What all three have in common is simple: too little creatine in the brain. That's why symptoms often include developmental delay, speech delay, and learning difficulties. And sometimes autism-like traits, hyperactivity, seizures, or movement abnormalities. So how do you test for it? Think of it as a three-step approach. Step 1. Blood and urine metabolic screening. You're looking closely at GAA and the relationship between creatine and creatinine. High GAA points more toward GAMT deficiency. Low GAA points more toward AGAT deficiency. And in boys, a markedly high urine creatine to creatinine ratio can suggest SLC6A8 transporter deficiency. Step 2. Brain MRI with MRS, magnetic resonance spectroscopy. This helps you see whether the brain's creatine signal is clearly reduced. Step 3. Genetic testing to confirm the diagnosis. That means checking GATM/AGAT, GAMT, and SLC6A8. Bottom line, CDS is essentially an energy system problem. On the surface, it may look like developmental or behavioral issues, but with the right workup, you can uncover what's really going on. Next, let's talk about why creatine deficiency syndromes, CDS, can look like developmental issues, behavioral problems, and sometimes even psychiatric symptoms. No matter which type of CDS we're talking about, the core issue is the same. The brain doesn't have enough creatine. Think of the creatine phosphocreatine system as a rapid, on-the-go energy buffer that neurons rely on. Most of the time, you don't notice it, but in critical moments, it matters a lot because the brain doesn't always use energy slowly and steadily. A lot of brain function is high demand and sudden. Thinking, speaking, learning, emotional shifts, and even bursts of abnormal electrical activity, like seizures. In those moments, neurons need to restore energy quickly and regain stability. That's when the creatine system helps fill the gap, so the brain doesn't crash into instability. But when that energy buffer system is running low, three high-demand processes tend to suffer first. First, communication. The more actively neurons are signaling, the more energy they need. Second, electrical stability. After a neuron fires, it has to pump ions back into place to reset, and that takes a lot of energy. Third, development and learning. A developing brain is constantly building connections, pruning circuits, and forming memories, work that is extremely energy-intensive. That's why CDS can show up as things that look like developmental or behavioral disorders: speech delay, learning difficulties, attention problems, autism-like traits, and sometimes seizures or unusual movement patterns. Now, the three major types differ mainly in where the breakdown happens. Sometimes production is reduced, sometimes the pathway gets stuck and something builds up, and sometimes delivery fails. Type 1. Agate deficiency, also called GATM deficiency. Reduced production, lower overall supply. Agate deficiency affects the first step of creatine synthesis. In simple terms, a key intermediate isn't made properly, so downstream creatine levels are lower. Symptoms are often relatively milder compared with other types. Mild to moderate developmental delay, speech delay, and learning difficulties. Some individuals have social communication or behavioral challenges that can resemble the autism spectrum. Low muscle tone or muscle weakness can also be seen. Because there isn't a buildup of an intermediate thought to be harmful, and the transport system is intact, this type is often considered the mildest of the three. You can think of it as lower energy reserves without extra interference. Type 2. GAMT deficiency, low energy supply, plus buildup of something that may disrupt the brain. GAMT deficiency can be a double hit. It affects the second step of synthesis, where the intermediate GAA is supposed to be converted into creatine. When that step doesn't work, two problems happen at once. Creatine is even lower, so the brain is more vulnerable to energy shortage, and GAA becomes elevated and accumulates, which is thought to potentially interfere with brain stability. So this type is often more severe, more noticeable developmental and speech impairment. Seizures are more common, and behavioral symptoms can be more prominent. Hyperactivity, impulsivity, autism-like features, and in a smaller number of cases, self-injurious behavior. Movement abnormalities can also occur, things like poor coordination, unusual gait, or involuntary movements. A helpful way to picture it is, not only is the energy buffer low, but there's also buildup that can destabilize the system, making seizures and complex behavioral or movement symptoms more likely. Type 3. SLC6A8 creatine transporter deficiency, CTD/CRTR. Production is possible, but delivery fails. In transporter deficiency, the main problem isn't production, it's delivery. Creatine may be made, but the transporter doesn't work, so creatine can't effectively enter brain and muscle cells. So from the outside, it may look like creatine is being produced, but the cells that need it most are chronically undersupplied, and brain creatine remains low. Common features include speech delay, learning difficulties, or intellectual disability. Autism-like traits or ADHD-like impulsivity and hyperactivity are common. Some individuals have seizures. Low muscle tone, fatigue, constipation, and poor weight gain can also be seen. Because this condition is X-linked, boys are typically more affected. Female carriers can vary widely. Some have little to no symptoms, while others may have learning or behavioral challenges, and a smaller number can be more clearly affected. In one sentence, the factory can run, but the delivery truck is broken, so the brain stays underpowered. Bottom line, all three types of CDS share the same core problem. Low creatine in the brain means less energy buffering, and the system becomes easier to destabilize. The difference is where things go wrong. GAMT deficiency, mostly lower supply. GAMT deficiency, lower supply plus accumulation of GAA. SLC6-8 transporter deficiency. It can be made, but it can't get where it needs to go. Once you understand that, it becomes clear why CDS can look like developmental or behavioral disorders, and in some cases, even psychiatric symptoms. It's not overthinking. It's the brain struggling at an energy level to stay stable. Now let's talk treatment. A helpful way to think about these three forms of creatine deficiency syndromes, CDS, is as one energy supply chain. The breakdown just happens at different points. When the problem is in production, it's usually easier to replace what's missing. When the problem is in transport, it's much harder. 1. AGAT/GATM deficiency. Can't make enough, but delivery still works. In AGAT/GATM deficiency, the first step of creatine production is impaired. The body can't make enough creatine, but the transport system is largely intact. So the approach is straightforward. Long-term creatine supplementation at medically supervised doses, not the casual gym supplement approach. This type often responds best to treatment. If supplementation starts in infancy, it may greatly reduce developmental impact, and in some cases help prevent obvious intellectual or motor delays. Even with a later diagnosis, many people see noticeable improvement in low muscle tone, weakness, and fatigue after a period of treatment. 2. GAMT deficiency, low creatine plus buildup of GAA. GAMT deficiency is more complicated because it's a double problem. Creatine is low, and the intermediate GAA builds up, which is thought to interfere with brain stability. Treatment is often a combination strategy. Replace creatine to address the deficiency as much as possible. Lower GAA, commonly by adding ornithine, along with a diet that restricts arginine and overall protein. Some clinicians also use sodium benzoate to help reduce GAA further. With consistent treatment, many patients may see improvement in seizures, behavioral symptoms, and movement issues. But if diagnosis happens very late, established language or cognitive impairment may be difficult to fully reverse. The key point is simple. The earlier it's found and treated, the better the outcome. Some children identified and treated in the newborn period can develop close to typically. 3. SLC6A8 creatine transporter deficiency, CRTR/CTD. It can be made, but it can't get in. With transporter deficiency, the main challenge is that even if you supplement creatine, it still may not enter brain cells because the transporter, the delivery worker, isn't functioning. Clinicians often try high-dose creatine, sometimes combined with creatine building blocks like arginine and glycine. But overall, response varies widely, and in many cases it's difficult to significantly raise brain creatine. So for this type, a more realistic plan is long-term management. Treat seizures using standard protocols and provide sustained support, speech therapy, behavioral interventions, special education services, and rehabilitation to maximize daily function. Follow-up matters, because these treatments are typically long-term. For people on long-term creatine supplementation, many clinicians recommend checking kidney function yearly as a precaution. Brain MRS, magnetic resonance spectroscopy, may be repeated to see whether brain creatine is improving and to help guide dosing. And some research in a group of boys with CRTR deficiency has reported QTC prolongation on ECG in a subset, so follow-up may also include ECG monitoring to watch for potential rhythm concerns. Bottom line, synthesis defects, AGAT, GAMT, are usually more cause-targeted and more treatable. Transporter deficiency, CRTR, is currently the most challenging, but structured, ongoing management can still lead to meaningful improvement. One day, your child isn't just struggling a bit in school anymore. It's like she becomes a completely different person. She starts hearing voices that aren't there. She screams, panics, tries to run, and she's absolutely convinced. Someone's trying to hurt me. Someone's poisoning me. And then comes the line that hits the hardest. She looks straight at you and says, coldly, "You're not my parents. You're imposters." She doesn't even recognize home anymore. She keeps repeating, "This isn't my house. My real house was copied. I'm not in the right home." What would you think? Most people's first thought would be psychiatric illness, maybe an acute psychotic break. Doctors would be alarmed too, because when psychiatric symptoms explode this suddenly, it can sometimes point to something even more dangerous in the brain. Catatonia, encephalitis, or an immune process attacking the brain. And today's story comes from a real patient, reported in Neurology in 2025. A 17-year-old high school girl. Looking back, she had always been a little behind. She didn't start walking or talking until around age 2. She had long-term speech therapy as a child. In high school, she still had mild learning difficulties. She needed an individualized education plan, especially for math and reading. But overall, she could go to school. She could manage daily life. Her family never imagined anything like this was coming. Then she got a very ordinary cold. And after that, everything changed. Fast. Within about a week, her family saw changes they couldn't explain. She began having auditory hallucinations, as if someone was talking to her, commanding her, threatening her. She became intensely paranoid, convinced she was being targeted and poisoned. She had sudden panic, screaming, emotional collapse, and then something even stranger. At times, she would seem to freeze. She'd stop moving, stop responding, and then later come back. But she didn't feel like the same person. It was as if her personality and her whole state had been replaced. But what shattered the family most wasn't just her fear. It was that she stopped trusting them. Around the time she was hospitalized, she developed a rare and deeply unsettling symptom. She misidentified the people closest to her. She became convinced her parents weren't her real parents, but identical replacements. That specific delusion has a name, Capgras syndrome. The belief that a familiar person has been replaced by an identical-looking impostor. At one point, she even said, "My dad poisoned me." At the same time, she insisted her home had been duplicated. "I'm not in the right house. This isn't my real home." That's another type of misidentification delusion, reduplicative paramnesia. A person becomes convinced a place has been copied, replaced, or exists in two identical versions. This wasn't just emotional overwhelm. It wasn't random, chaotic confusion. It was a structured, consistent, delusional system. In her world, familiar people and familiar places had turned unfamiliar and dangerous, as if reality itself had been rewritten. If it had only been hallucinations and delusions, It might have been easier to treat this as primarily psychiatric, but her body was sending warning signs too. She had episodes of whole-body stiffness. Her hands would suddenly jerk or twitch. Her walking became unusual, stiff, almost mechanical. On exam, doctors also observed a movement pattern that looked like brief loss of support, a type of involuntary jerk. Psychiatric symptoms plus abnormal movements forced the team to seriously consider encephalitis or autoimmune brain disease as well. So the testing began, again and again. Brain MRI was normal. A lumbar puncture was also normal. No clear inflammation in the CSF. Infectious testing was negative. Autoimmune encephalitis testing was negative. Extensive blood work didn't reveal much either. Except for one small clue. Her serum creatinine was low. When the tests don't give an answer, doctors often have to treat the most urgent possibilities first. They tried medication aimed at catatonia. She calmed briefly, but soon worsened. The hallucinations and paranoia intensified. She developed a strong urge to flee. Then they did an EEG. She wasn't having a classic seizure, but her brain activity looked unstable, high risk. They started anti-seizure medication. Her EEG improved, but her psychiatric symptoms didn't resolve. The team still worried about missing autoimmune encephalitis, so they tried immunotherapy. She improved for about a day. Then she crashed back again. The misidentification, paranoia, and terror returned. That's when the team stepped back and asked a critical question. If this isn't primary psychiatric illness, and it isn't encephalitis, what are we missing? Because she'd had developmental and learning difficulties since childhood, they shifted to another direction: genetics and metabolism. They ordered targeted metabolic testing and genetic testing. And suddenly the puzzle opened up. A substance called guanidinoate acetate, or GAA, was markedly elevated, while creatine was low. Genetic testing confirmed an autosomal recessive condition, GAMT deficiency, and brain MR spectroscopy, MRS, showed something striking. The brain's normal creatine signal was nearly absent. In other words, her mind didn't suddenly break. Her brain had been missing a critical energy support system for years. The infection acted like a trigger, pushing an already fragile system into full imbalance. And that imbalance exploded outward as symptoms that looked intensely psychiatric: hallucinations, persecutory delusions, misidentifying her parents, and believing her home had been copied. Once the diagnosis was clear, the treatment finally matched the cause. They supplemented creatine to rebuild the brain's missing energy buffer. They used strategies including ornithine to help lower the harmful metabolite that had accumulated. And they also used antipsychotic medication to manage the acute psychiatric symptoms. This wasn't an instant turnaround story. At first, she worsened to the point that she barely spoke and needed help with daily care. Her family feared it might be irreversible. But as the team adjusted the plan, increasing doses and using combination treatment, she began to come back little by little. At follow-up, her family described it in one sentence: she's back to about 85% of who she used to be. Most importantly, she no longer insisted her parents were imposters. She no longer believed her home was duplicated. The delusions and fear, symptoms that looked like schizophrenia, gradually faded. Her daily functioning returned. She regained independence in everyday activities. And this case leaves 3 takeaways for everyone. First, not everything that looks like a psychiatric breakdown belongs only to psychiatry, especially when there are unusual movement findings, EEG clues, and a history of developmental or learning challenges. Second, normal MRI and normal lumbar puncture don't mean nothing is wrong. Some genetic metabolic disorders require the right tests: metabolic screening, MRS, and genetic testing. Third, the key isn't who was wrong at the start. The key is whether the team can step back when treatment isn't working and widen the frame. Because for some conditions, what changes the outcome isn't stronger sedation, and it isn't more aggressive immunotherapy. It's a simple but crucial strategy. Replace what's missing and reduce what's building up. This girl looked like she had suddenly lost her mind. But in reality, her brain was sending an emergency signal in the loudest way it could. And when someone caught the right clues, it became possible to bring her back. If you're interested in stories at the intersection of inherited metabolic disorders, IEMS, and mental health, including cases of metabolic psychosis, you can check out the full written version in the Junyi column.